Hey everyone, welcome back. Thanks for listening and tuning in to the I Believe podcast. Today I'm joined by Dr. Kevin Burns at Providence Mission Hospital at Mission Viejo. I am so excited to talk to Dr. Burns today about histotripsy, which is a new FDA-approved liver procedure that is specifically okay for liver tumors. Dr. Burns, could you just tell us a little bit about what is this new treatment that we have?
Histotripsy, the company that makes it's called Histosonics. They've been developing this technology for about 20 years, so it's not something that's brand new. It's finally available commercially. So it got FDA approval last fall for use in liver tumors. I know that has a lot of application to patients with uveal melanoma. So this procedure is kind of different than a lot of the other procedures you may have heard of. It is, first off, non-invasive. So it uses ultrasound waves that are guided using imaging directly to a tumor inside the liver, and it can kind of instantly pulverize that tissue or that tumor without any incisions or anything like that. So it's a new non-invasive way to ablate liver tumors.
Sounds super awesome, and I guess I'm a little bit biased since you did one for me. Can you just walk us through maybe a mock treatment procedure of histotripsy if a patient were to receive histotripsy?
So the procedure, I think one thing to know is it is done under general anesthesia, at least for now. I mean, there may be a future where we don't use that. Main thing is the procedure can take a little bit of time. You may be in an uncomfortable position, and as you think about it, your liver's in the top of your abdomen. Every time you take a deep breath in, your liver can move around. So if we can put you completely to sleep, we can control that breathing to make sure that nothing moves around while we're doing the treatment. Generally, you'll meet with a physician that can perform this procedure. That can be done by an interventional radiologist, a surgeon. I think maybe some radiation oncologists also will be getting into this, just to make sure that you're a candidate. Not every lesion and not every location in the liver would be an ideal candidate, and there may be better treatment options for certain tumors. So you first need to make sure that you are a candidate for it. If you are, then the day of the procedure, you generally come into the hospital. You're going to be there for probably about half the day. You'll check in like any other procedure. You will get put to sleep. There's a lot of setup, maybe about 30 minutes just to get you positioned correctly, make sure we can see the tumor, and then you might have to look at some pictures of what this device looks like, but a very big kind of water bath goes on top of you. This uses ultrasound energy to deliver sound waves into the tumor, and so sound waves don't really travel that well through air, so we have to get all this kind of water, and so that the sound waves travel from the device through the water into your body and are directed into the tumor. So this big water bath goes on top of you. We use the device, that's the Edison device by Histosonics, to use ultrasound to find the lesion, and then we kind of plan out our treatment volume. So, how much margin do we want? How much tumor coverage do we want? Are there any critical structures nearby? So plan all that out. And then we send some test pulses in to make sure that they're going into the correct location, and then the treatment turns on. Treatment times for each tumor can vary. It's size dependent, depth dependent, so it's a physics thing. And so treatments, can vary from 5 minutes to 1 hour. It can really vary. Every tumor is different. And then after that, patient gets woken up, and it's an outpatient procedure, generally discharged in 1 to 2 hours. Outpatient procedure, and afterwards, I would say pretty minimal symptoms. Usually some patients have some mild pain afterwards, but it's generally very well tolerated. Tylenol, Motrin, over-the-counter medications. And so outpatient procedure, and I guess to note, we can treat 1 tumor, 2, 3, we can treat multiple tumors. We have treated up to 6. I think physicians treated up to 9 in one time. Things are definitely evolving with this procedure.
Where are you specifically located, and how could somebody find another procedure area that does histotripsy?
I'm in Orange County, California, so Southern California. We were one of the first sites. We're the first site in California to have this technology, so we started doing procedures in February of 2024. It's a very new technology. It is expanding. I mean, this is going to become much more prevalent soon. I think at the time we got it, I think we were one of the 8th sites to get it. Hopefully by the end of the year, they'll be in 20 to 25 sites in the United States. So it's definitely expanding. The Histosonics website has a physician finder. So if you go to their website, I think it's just histosonics.com, you can locate a hospital near you and kind of contact a provider that can do this for you. We have a website specifically for this as well. If you just Google, Providence Mission Hospital Histotripsy, I think our website will come up and has a lot of information about the procedure and ways to get in contact with us.
Why do this with an interventional radiologist versus there's a surgeon, there's radiation oncologists, and what are some of your kind of opinions as to why histotripsy is maybe a little bit more beneficial for a patient, depending on where they are in metastatic disease or any kind of liver tumor presentation?
Sure. Yeah, so I don't think it matters too much who does the procedure. Each different specialty is going to have other things they offer. So, a surgeon is used to treating patients with liver metastasis, and IR is used to treating somebody, and a radiation oncologist. We're kind of all different physicians that use a lot of other technologies to also treat liver metastasis or liver tumors. And so kind of everyone brings something to the table here. When somebody has liver tumors, unless you can have a really cure. So for example, in colon cancer, for example, if somebody has colon cancer that spread to the liver, often they will try to do surgery to remove all the liver that has tumors if possible, because in theory you can cure that patient by getting all the tumors out. And somebody who has metastatic disease from other primary locations that may get more tumors in the future, kind of one of the goals is also preserving the liver function. So, it may be more beneficial to have these minimally invasive treatments, especially histotripsy or other therapies, to preserve as much liver as possible so that we can keep attacking tumors if they do develop over time. So I'm sure people are aware of kind of a lot of the other options. Surgery is an option, radiation, external beam radiation. You can have embolization, you can have immunoembolization, you can have Y90, microwave ablation, and there's new things coming on the line specifically for uveal melanoma as well. So there's kind of a lot of options. So if you talk to a physician about this procedure, they may say something else is actually better for you in this situation. But I think histotripsy has kind of a lot of promise so far. We've treated a lot of patients. We have a lot of patients that are many months out from therapy, so we have all their follow-up imaging. And what we're seeing is it's very effective for local control, meaning the tumor we are treating, we are killing. And we're not seeing much damage to any of the surrounding liver, which I think is one of the important things for this procedure. So we're really seeing that the treatment area is involuting, or kind of retracting, getting absorbed, and there's not much damage to the parenchyma or the normal liver around it. When you do other procedures like microwave ablation or Y90, which is a common thing we do as well, there can be a lot of collateral damage around the liver, scar tissue that forms. Specifically, differences between this and microwave. Microwave is going to kill the tumor. It's very effective at that, and that kind of necrotic scar tissue is just going to stay in that piece of liver forever. And so, on follow-up, there's always going to be a spot there. We just want to make sure that it doesn't enhance or take up contrast when you get follow-up studies. But with histotripsy, we're seeing that cavity actually kind of reabsorbs and contracts inwards.
Super interesting. All of these imaging pieces, I guess it's just a little bit ambiguous for me, but like that idea of seeing it just basically reabsorb in the liver, that seems super powerful. So let's cover some kind of commonly asked questions for histotripsy, unless you have something else you want to add.
I was going to say that, a lot of this stuff has been studied in animals and things like that. So we think that the lysate, or the tumor, the ablated tumor, really gets absorbed by the lymphatic system. And that's why that area kind of can clear out.
Yeah, that's super neat. What is too small or too large to treat in your experience?
So I don't think there's really necessarily size criteria. It's all going to depend on the patient. I think one of the caveats will be if a lesion, first of all, if a lesion's smaller, that's much easier to get a kind of complete control. So you want to treat small lesions, but things need to be able to be seen, or else you have the chance of missing the lesion. So this uses ultrasound. So I'm sure people are familiar with ultrasound. That is looking at the liver. It's different than a CT. It's different than an MRI. So oftentimes your imaging is either going to be a CT or MRI, and we're trying to find that finding that's on the MRI or the CT, and it may look different on ultrasound. So if a lesion's 5 millimeters, it may be more difficult to pick up on ultrasound. We can utilize tools to help us. So the histotripsy machine has what's called fusion, where it can take your pre-existing MRI or CT that showed the lesion. We can fuse that with the ultrasound that we're showing, and it can help guide us to the correct location. So in theory, even if you can't find the lesion, you could localize it with fusion imaging and apply a treatment to an area, even if you can't for sure see a lesion. So that would be the case of a small lesion. Each treatment zone can be about kind of 4 centimeters or so. Pretty standard is for any tumor type. Anything over 3 centimeters is really hard to get with an ablation for curative margins. So that applies to all technologies, microwave, all that sort of things. And so if a tumor is bigger, we can do overlapping ablations to cover a larger area. But when a tumor is much larger, and especially if you have one tumor, there could be other options that may be better suited for you. But if the goal is really debulking, it can still be done for that, and it just could require multiple treatment areas to cover the entire tumor. So if a tumor is 10 centimeters, it's probably not the best option for you. And there's probably other options, possibly surgery, Y90, other things like that may be better to treat a tumor like that.
Oh, that makes sense.
We are going to have some integration with CT, so we could do a CT scan while you're in the histotripsy procedure. So we give you contrast in your IV. We can take a CT scan using what's called cone beam CT. That information can get loaded into the histotripsy machine and help guide the treatment arm directly to where the tumor is. So even if we can't see a tumor with ultrasound very well, say we're looking through the ribs and we can't see very well, we can actually now use CT to help guide our treatment.
Well, the fusion imaging sounds super cool, and it sounds like that's just one way kind of layering to make sure that you guys accurately treat an area. What are some of the other ways that you verify accuracy before and after of a histotripsy procedure for someone?
So during the procedure, we do a planning ultrasound first. So usually before you have the procedure, you'll have an ultrasound, usually with one of the ultrasound techs that probably helps with this procedure so they know what's going to go on. First, to make sure that we can actually see the lesion, make sure it correlates with the lesion we see on imaging, and figure out positioning, make sure it's a safe treatment for you to do. During the procedure, this is all done under live ultrasound. So while the treatment is actually going on, we can see live. We can see what's called the bubble cloud, which is the focal point of all the ultrasound energy hitting, and we can see the ablation happening in real time. Say you were to move during the procedure, we can see live to make sure that we're still treating the same area. Sometimes you can use landmarks, so meaning we know where all the veins in the liver, so we can use that to help guide our area. And we also do follow-up imaging. In general, we will do a CT scan after the procedure just to verify our treatment zone. It really helps with follow-up, so we can see what our immediate ablation cavity looks like. And so when you get follow-up imaging, usually an MRI in about 1 month, we can compare that to the immediate imaging to the follow-up to make sure that we know kind of where we treated.
So you mentioned kind of this overlapping ablation zone. So how many tumors can you treat theoretically at once with histotripsy?
There's not a limit so much. It's going to be more of a time limit. Each tumor requires you to plan out the tumor, provide a treatment, and you are under anesthesia for this procedure. So it's really just going to come down to patient safety from that standpoint. You also don't want to ablate too much liver volume at one time. This procedure is generally very safe, very minimal, complications, but we don't want to overdo things. We can always stage these procedures where we can do multiple lesions, have you come back usually in about a month or so. There's no real guidelines on this, but just to make sure that you're doing okay from the treatments, and we can actually go after more tumors. Everyone's different. So if you have 20 tumors, going after them one by one may not be the best option. That's why, it's important to talk with your doctor about what's the best option for you. But this, even if you have multiple tumors, this could be part of your kind of treatment algorithm. We have several patients who have come back for multiple treatments where we keep going after more and more tumors. Really, those patients have been told they don't really have any other option when they're tolerating the procedure very well and they're having good results. And so we're going to kind of keep going after tumors until there's nothing left to treat.
So it sounds like this is something that obviously depends on patient by patient case analysis, just to determine who needs what and when, but that generally you guys are seeing that there's some room for maybe some creativity or just some individualization for each of the patients that you treat.
I'll say things are definitely evolving over time. I think one of the important things to note is, we've started using this technology a couple months ago. We've had software changes. There's incoming software changes. So there's really, this machine isn't just static, it's actually improving over time. The treatment head, which is, I encourage everyone to go look at, type in Histosonics Edison just to see what a picture of this looks like. The treatment head is going to be changing to a kind of a better one that has some less limitations. So there's a lot of improvements that are coming with this. This is the Generation 1 platform. So there's going to be a lot of improvements coming future. And, speaking to that, currently we're treating liver tumors. This is coming to other organs soon. The device is really made to treat the abdomen. And so other organs, kidney, pancreas, prostate, those things are going to be coming online over the next couple of years.
So you mentioned that most patients that you've seen are tolerating the procedure pretty well. What are some of the risks of the procedure, kind of the side effects that they might experience?
I would say the most common is really the days after the procedure. It's called post-ablation syndrome. It's similar to a lot of the other modalities, microwave ablation, Y90, TACE, you can get all these sort of things. I'd say the most common would be getting a low-grade flu and kind of feeling under the weather for the couple days after the procedure. Some people do not get this at all. I think it really depends on the volume that you're treating. When you kill off a tumor and the tissue around it, your body's kind of immune cells and go in and start cleaning up the area, and that sets off an inflammatory reaction in your body. And so those are all things that we just control symptom-wise. Stay well hydrated, make sure you're eating well, but there's nothing really we need to do about it. I would say some patients have some mild pain or discomfort as well, but that's been much, much less than any of the other procedures that we do. So comparing to microwave ablation, I would say much less pain if a patient has had that done before.
Just in my experience, at least, I am one of your patients, and so I had histotripsy done on one lesion, and I was fortunate enough that it was probably small enough that the volume, didn't yield any kind of an immune reaction or any kind of like a fever or flu feeling.
The immediate response, yeah.
Yeah, like the immediate response. Like I didn't feel super tired. I didn't feel super sick or I had zero pain, to be honest. And the very next day I went to the beach that you recommended with my kitch. So it was kind of astounding to me to come from 6 weeks prior doing a liver surgery where I had a microwave ablation, a partial resection. It was all done laparoscopically, to then go to this and have something so non-invasive that I could literally go to the beach within 24 hours. So that felt really, just for me as a mom, that felt really, really good.
Yeah, I think this procedure is kind of amazing for that standpoint, the non-invasive nature. We have a lot of options, and I think for the right candidate, this procedure is excellent.
Yeah, for sure.
Yeah, because it doesn't really affect your quality of life. So especially if you've got a lot of stuff going on or you're sick with other things, it's not a major operation you could have with other procedures. I think what we can touch on one other thing too is if patients are on chemotherapy, we're not pausing any systemic therapy for this procedure. So it's pretty common for patients who are having surgery or other sort of interventions where chemotherapy may get temporarily put on hold to help with wound healing, make sure that you're safe enough to have a procedure. But with this, we're really continuing all systemic therapies. Yep.
Well, and that's really important too for things like we have, at least in uveal melanoma, we have FDA approval of Kimmtrak, which is immunotherapy specifically for only some HLA types, for those of you listening. But this is unique in the sense that if Kimmtrak is maybe controlling the majority of your liver tumors, but maybe there's one rogue tumor, I feel like I hear that happen so many times with patients where they have just one rogue tumor that just keeps growing a little bit despite the treatment working for everything else. This sounds like it could be a really unique option for that.
Yeah, I think that's in all cancers too. A lot of cancers respond really well to immunotherapies, chemotherapies. But say you're doing really well on therapy for a year and now, like you said, you have one tumor. That one may have some new mutation or something that's overcoming your systemic therapy. So instead of potentially changing your therapy, it may make more sense to ablate that tumor, use histotripsy or other modalities to kill that tumor and maintain yourself on your current therapy because it seems like it's working.
So what overall would you say is the goal with histotripsy when you're treating a patient with uveal melanoma mets to the liver?
So I would say we're always going for excellent local control. So if we're ablating a tumor, we want the entire tumor treated. We want a margin. That's where you get a little bit extra around the tumor to make sure that all the cells are encompassed. So that's the primary goal, is to really kill off that entire metastatic lesion. In the development of histotripsy, so there's a lot of scientific papers that people can look up if they're interested. All this pre-human research, it's all generally done in mice, so things don't directly translate to humans, and that's why we're going to be collecting a lot of data to see if this applies. But in animal models, histotripsy was shown to be much more immunogenic than a lot of the other procedures like radiation, ablation, or surgery, because it is a non-thermal energy. I think that's an important thing maybe I didn't mention earlier. So it's non-thermal, it's non-radiation, so it's actually mechanical disruption of the tissue. And histotripsy is either 100% on or 100% off. So as soon as it turns on in that cellular area, that is dead. Those cells are ruptured. Everything is basically non-viable in that area instantly, but there's an exact margin. There's not a gradient like we see in other treatment options. So we can actually treat near critical structures as well. We can treat near bile ducts, blood vessels without actually risking injury to them. And what that does is it kind of opens all these cells up, and there may be some antigen or a protein that's inside the cell that has been hiding from your body's immune system that now potentially could be unmasked. We don't have, this is all anecdotal evidence in humans currently. We don't have papers and all that stuff. We need a lot more data to prove this. But there is this possible ability to help prime your body or help your body recognize what's inside the tumor to help it start attacking other tumors in your body. And there may be a lot of interactions or synergy that could be done with immunotherapies, checkpoint inhibitors, and each tumor type is going to respond differently to this. And so there's a lot of data we're collecting. There's going to be a registry starting where we're going to kind of collect it on every patient we're treating to see if we can figure out who is having this immune effect, if it's even happening, what medications they're on, to help give the best treatment to everybody. I think that's one of the promises in the future, is to make this it's an ablation treatment. We're treating a tumor, but it may be some sort of local immunotherapy systemic thing, but that'll always be in combination likely with some sort of systemic medication. But I think that's the long-term promise with this procedure.
Yeah, I'm so grateful that you were able to come on and just talk to us a little about this, give us a little bit of a background, and then, like you said, there's lots of things that people could Google and the studies kind of coming or studies that have been done recently that people could find information on. If they wanted more information, you mentioned the Histosonics website, and we can put that in the show notes as well. As we conclude, is there anything else that you want to say regarding histotripsy and just patients asking about it or pursuing this as an option in their care with an interventional radiologist or whoever might be doing the procedure in their area?
Sure. I think it's a new procedure also. So, you may ask, your oncologist may not be familiar with this. This is brand new. So, if you're really interested in it, it might be worthwhile just go to the website, reach out to somebody who's close to you that can do the procedure, at least to answer questions about it. It may not be right for you, but I think it's worth getting some information if it's something that interests you.
All right. Well, Dr. Burns, thank you so much. I appreciate your time, and we are so grateful for your expertise. And if you guys have any other questions, then please tune in to future episodes. We're going to be talking more about liver-directed therapies, and there's just lots of options to gain some knowledge around what you can do with metastatic liver disease in uveal melanoma. So, Dr. Burns, thank you so much for joining us.
Thank you.